Epic organizations. We also have a cloud and technology division as well that does works with organizations moving to public cloud, so offering disaster recovery solutions leveraging Amazon Web Services. I'm here today to actually introduce Micky Tripathi. So here at the New England HIMSS, somebody that probably doesn't need a long intro, but Micky is the President and Chief Executive Officer of the Massachusetts eHealth Collaborative, a nonprofit health IT advisory and clinical data analytics company. Micky is also active in the industry at a local and national level, including being on the board of directors of the New England Health Information Network, the Sequoia Project, the Karen Alliance, and the Fire Foundation, and project manager of the Argonaut Project. In industry collaboration accelerated the adoption of the FHIR protocol. He is also the affiliate of the Berkman Klein Center for the Internet and Society at Harvard University. Prior to joining the Massachusetts eHealth Collaborative, Micky was the manager of the Boston office of the Boston Consulting Group, a leading strategy and management consulting firm. While at BCG, he served as the founding president and CEO of the famous Indiana Health Information Exchange, an Indianapolis-based nonprofit company partnered with the Registry of Institute to create a statewide health information infrastructure in the state of Indiana. As a manager of BCG's healthcare practice, Micky also served a variety of US and international clients in the nonprofit sector, as well as bioinformatics, biotechnology, and pharmaceutical industries. Without further ado, please welcome Micky.
Thanks so much. Good afternoon. Good afternoon. Hi, thank you. Thank you for the kind introduction. I asked him to shorten it a lot, but he didn't, so, but thank you very much. I have a dog named Charlie. He's 12 years old, and in dog years, you can do the calculation. So he's got some health issues. So last week, I brought him to our vet, our local vet, VCA Rotherwood in Newton, and they, sort of looked at a bunch of things, and they said, we see something weird. We think we should do an ultrasound. So they said, come in tomorrow. We'll get the specialist in, and he'll come in and he'll do an ultrasound, and then we'll take it from there. So they did the ultrasound. They found what looked like a suspicious mass on his spleen, and said, geez, we think you really ought to go to a specialist. It could be a couple of different things here, but you really ought to, go pretty fast. He's very healthy otherwise, so we should figure out what this is and see if we can nip it in the bud. So, so I went to Angel Medical Center in Jamaica Plain. We got an appointment within a week. Went to Angel Medical Center, saw Dr. Trout. Haha, I'm not kidding, Dr. Trout. And Dr. Trout is a surgeon, right? So I went to Angel Medical Center, walked in. Angel Medical Center, for those who don't know, is the equivalent of an academic medical center, right? It's probably one of the premier academic medical centers in veterinary medicine in the country. So walked in, Dr. Trout met me. I walked in the room. First thing I saw was they had an electronic medical record. Second thing I saw, he had a scribe. He actually had a scribe. Right? And so we go through the whole appointment, and the scribe is documenting everything, and and I'm kind of amused by the whole thing, and he's examining Charlie and talking to me, and just saying a whole bunch of stuff to to the scribe, and then he says that, he gets sort of the background and does a little bit of the history with of Charlie, and then says, so what exactly did they find that sent you here? And I kind of described it, and he turned to her and said, do we have the records? And she said, well, of course we have the records. And she went right in, and he said, do we have the lab work? This is just from last week. She said, do we have lab work? And she said, well, yeah, here's the labs right here. And she flipped the computer. He looked over, went down the labs. He said, oh, okay, that looks mostly normal. Concerned about this or this or this. And then he said, and I understand that there was a suspicious mass. And then he turned and he said, do we have the ultrasound results? And she said, well, I'm sorry, we don't have the Cineloop, but we do have the interpretation here. So then he was able to quickly go, read the interpretation, and then he went on with his, with the examination, right? I was pretty impressed, actually. That doesn't happen in most human engagements that I've seen, especially on such short notice and in such a sort of easy manner between the scribe and the provider, going back and forth, each doing what he or she sort of did best in those particular roles. And so on the way out, I asked him, I said, so it turns out I work in electronic medical records and interoperability. I was pretty impressed with that. So I'm surprised that you have a scribe. Do a lot of veterinarians have scribes? And he said, well, I like to spend my time with the patient. And he said, and dogs, he said, dogs only have body language. It's not like I can be typing and talking. The dog is all about body language, so I really need to be looking at the dog, touching the dog, and besides, I'm not really great at the computers. And he said, but also the other thing that we need the scribes for is when I do surgery, we provide the owner with text updates along the way of how the surgery is going, and then we take a picture of the dog coming out, and then we send a picture to the owner, and we do all of that via text. And he said, I can't possibly be doing that, as a surgeon and everything. And I said, wow, I said, do you find that hard or cumbersome? And he's like, well, he said, in his these are the parting words as I was leaving. He said, it's not good or bad. It's what the world expects. So that's what we're doing. So anyway, I was very impressed with that, and it offered a lot of lessons, I think. One of the big lessons was none of this was about technology, right? None of it was about technology. Now, of course, they don't have to worry about authorization and privacy and HIPAA. They're able to just pick up the phone, say, hey, can you Gmail these records over? However, I didn't get into, do you have a Kara quality equivalent? Do you use direct messaging? But somehow all of that got in there automatically, and it worked pretty well. So that's one of the themes I think we'll come back to, is that this stuff isn't about technology. It's all about policy. It's all about sort of motivation at the end of the day, and then being able to use the technologies in certain ways to act on the motivation that you want. So first thing I want to cover a little bit is from a survey from HIS Talk. How many of you follow HIS Talk, the blog? So some of you may have actually responded to this survey, but not a lot of you actually. It's a great blog. I would actually highly recommend just going on there. A lot of organizations I know, and particularly CEOs of organizations I know, sort of religiously check that every morning to make sure that there are no disasters involving their company, and then they can carry on with their day. So it's kind of a good place for industry gossip. But he had a poll. This is Tim, Mr. His Talk. He had a poll the other day, and these are non-scientific, right? It's just a web survey. So it's whoever responds, and it's obviously all sorts of selection bias and all of that in there. But the interesting thing about this is that the audience for these polls are health IT professionals, right? It's folks like all of you. So it's people who actually know about the technology, they know the insides and the guts of how this works. And so the question he asked is, when will every provider in every care setting be able to reliably exchange all clinically relevant patient information? And the options were more than 10 years from now or possibly never, within 5 to 10 years, within 3 to 4 years, within 1 to 2 years. Right? So how many of you say, let's just take the extremes, how many of you say more than 10 years from now or possibly never? All right. Actually, that doesn't even look like 5%, actually. Are most of you in the 5 to 10? 3 to 4? All right, and I'm not going to, 1 to 2, I don't want to shatter any illusions that you have. You're living in a happy world, and I think that's great. So here's the responses, actually, interestingly, right? 46% said more than 10 years from now or possibly never. These are health IT professionals, right? So there are two ways to look at this. One is, you could sort of take it at face value and be like, oh my God, we're never going to get this. But on the other hand, you could say, well, these are health IT professionals, so let's think about what they actually thought they were responding to. The question said every provider. It said every care setting. It said all clinically relevant patient information, when all of us know that's a moving target, right? All of those are moving targets. So if I was going to respond to this, I didn't respond to this, I probably would have been either in the more than 10 years from now, or this question actually doesn't make sense. And part of the reason I think it doesn't make sense is because underlying it is this notion of interoperability as a switch. And the switch metaphor I like to use because it's a sense that we just turn on interoperability and it'll be available for everyone, right? And all we need to do is just keep working really, really hard, and then we'll get there and we'll turn it on, and then it'll be available for providers, for payers, for public health, for life insurers, everyone, for patients. And that's all we need to do. When the reality is, I think as most of us know, that interoperability is more like a dimmer, right? Where there are some kinds of use cases where you really just need a little bit of light or a little bit of information, like an event notification system, or secure email, like Direct Trust helps to facilitate across the country. And then you can go all the way down in terms of the type of richness you need. Maybe a local HIE, which is geographically constrained, but might have a lot of rich data in it, versus a Care Equality or a Commonwealth, which may not have as rich data or may not have as high quality data, but they are nationwide and offer the ability to have baked into your EHR systems, and we'll talk about it in a little bit, talk about that more in a second, into your EHR systems, going all the way down to HL7 Fire and apps, which might offer a richer experience, and we'll talk about that as well. But the point is, there's lots of interoperability sort of options and a portfolio of interoperability. And so if we go back to that question, in a way, to me, that's just like, the question doesn't even make sense, because we can't turn on a light and light everything up overnight. So one question we may go back to then is, if, for those of you who aren't familiar with Commonwealth and Care Equality, these are two nationwide networks. They're consortiums of vendors and now others. The vendors represent a large fraction of the providers who use EHR systems across the country, and they're now connected. So as of last fall, they're in full production, connected across those networks, kind of like AT&T and Verizon Wireless finally being able to connect up their phones so you can make calls across the systems. And here's a map just from, I think from last week, right off that you can go to the Care Equality site or the Commonwealth site, and you can find which providers in your state, in your zip code, 5 miles from your office, 10 miles, whatever search criteria you want to use to see who's live. And as you can see, there are a lot of sites live, right? And these are just the ones who are live. This isn't just the, this isn't every Cerner site. This is just the Cerner sites and Meditech sites and all the others who are live, right? So there's a lot there. There's a lot there that's already live. So the question I would ask, and those providers who are, the vendors represent over 80% of all of the hospitals and ambulatory providers in the country. Right? So that's not all fully implemented yet, but now we're just in implementation mode in those networks. So over the next 1 to 2 years, maybe 2 years on the outside, we should see most of those vendors bringing live most of their sites on these two networks. Right? So that gets us to a point where in 1 to 2 years, something like over 80% of hospitals and ambulatory providers will have in their system the ability to do what? To query for and retrieve a continuity of care document, which I know isn't pretty, but it has that payload in it, right? The Common Clinical Data Set, now called the US CDI. So if we step back and ask the question again, is that nationwide interoperability? If I asked my sister, who's not involved in healthcare, which I did, and presented it to her like this, she was like, yeah, sure, I'd call that nationwide interoperability, right? But it sort of begs the question of, well, it doesn't do everything we want. It doesn't have data level stuff. It's not, not great for patients. CCDs are awful. So the point is that we're always going to want to get better and better and better. But I would submit that we're fast approaching a real threshold moment where we can sort of say, you know what, we've actually climbed the first hill. We've got the ability for most providers to be able to, within their own systems, go out and get clinical information that they want. And increasingly, it's automated. So the way these systems are working now, for example, in Care Equality, Athena Health or Epic or Cerner will actually do a geofence search of every single site that's live within a 50-mile radius, let's say, of that home site, and they'll bring back any records that match that patient overnight. So they'll look at your schedule overnight, go out and get all those records, bring them back so that you wake up in the morning and they're already there, right? So we always have this mental model of, oh, a provider, he or she is saying, oh, where is Leon Barzan? Okay, here, I'm gonna click that and it's gonna go out and come back. That's not the way it's working. The way it's working is they're doing it all overnight and bringing it all back to you so you have it there. Now your problem is how do you sift through all of it and make sense of it, not can I find it, right? That's a different problem. That's the problem we wanted to have, but it's not a problem. I don't want to undercut the fact that it's a problem, but it's a second level problem or a third level problem. So that's one perspective on where we are with nationwide interoperability. It's not perfect. Now we have these rules, right, from the federal government. Hopefully all of you have read all 800 pages of them and are very familiar with them. There's the ONC information blocking rule. That establishes that data sharing among providers really has to be the default, right? They carve out 7 exceptions. They say if you're not sharing data with other providers, you could be accused of information blocking and actually be fined. And they say, except there are 7 well-defined exceptions to that, general provision. And it establishes that FHIR APIs ought to be mechanisms for sharing information among, with patients, and it does all sorts of regulation and stuff. Then you have now the CMS interoperability rule, which is somewhat linked. This is the first time with the CMS interoperability rule, it's the first time that CMS is saying, you know what? Payers have to do all this stuff that we've been beating up on providers for since 2010, right? They're basically saying any health plan who we have a hook into, so it's not just Medicare and Medicaid. They're saying it's all the Obamacare plans, it's all of the CHIP plans, it's everything else that has any federal dollar whatsoever associated with Medicare. CMS is basically saying, we think you're under our authority if you received $1 from us, and so we're going to require that you meet all the same requirements that the providers have to with respect to making a FHIR-based API available to patients, letting patients get their data without your interfering with it, and having plan-to-plan interoperability when a patient goes from one plan to another. And allowing a patient to say, I want all my claims data to go to that provider, and I want to be able to do it through the FHIR API, right? That's pretty huge, I think. And it's the first time that the payer side is sort of falling under that same umbrella as the provider side. Then the last thing is we have the ONC Trusted Exchange Framework. I won't go into all the details of that unless people are interested, but it's sort of a governance mechanism for interoperability nationwide, kind of like Care Quality and Commonwealth, but there's lots of questions about whether it conflicts with that, but I won't go into that. But one of the things I want to talk about is that we've thought about interoperability in the ways that I was describing. We made a lot of progress with Care Quality and Commonwealth. Now these rules come along, and they have a little bit of a different perspective when you think about them. For any of you who've read them, if you read the preambles, it talks a lot about thinking about this in a different way. And that different way is thinking about it from a consumer or patient perspective rather than a provider perspective, right? So all of those rules are all about thinking about it a different way. So what's this weird diagram that I have up here? How many of you remember who Ptolemy was? Ptolemy? Hey, there's one person who remembers who Ptolemy was. Ptolemy looked up at the stars, right, 400, 500 years ago, looked up at the stars and looked at the way the stars were shifting by day, by night, by month, season, and he said, well, I know that the sun revolves around the Earth, right? I know that for sure, because the Earth is the center, right? It's a geocentric view of the universe, so I know that that's the way the world works. So how would I draw the orbits to fit that model? And that's what he came up with. He said, well, that must be the way the orbits work, because that's what I'm seeing, and I know that everything revolves around the Earth, so that must be the way that the world works, that the universe works, right? And you might imagine that we kind of are torturing ourselves by thinking that providers really ought to be the center of this, right? So we're saying we struggle with all these issues of, well, if the patient wants to get access to their data, they have to log into that portal, and that portal, and that portal, and that portal, and they can't aggregate their data nicely, and it's still not coded nicely, so they get it all into Health Vault or whatever app they're using, and it's still a mess, and they're having to figure it all out, and we torture ourselves by saying, oh yeah, well, that's just the way the world has to work, right? Well, why? Because we make the assumption that the patient has to be on the outside. And these rules actually say, no, 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 we're going to look at it differently. We're going to say that everything revolves around the sun. And what if we put the patient at the center of that and enable them, give them the ability to be at the center of that and actually be the conduit of interoperability, right? And you might think of that as a Copernican revolution. So Copernicus was the guy who ended up losing his head over this, but he was the guy who came and said, no, 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 that's really stupid. The reason that drawing is so screwed up is because because the Earth obviously revolves around the sun. And if you start with that assumption, then you can draw really nice orbits and everything starts to make sense, right? And in the same way, the CMS ONC rules kind of say the problem with interoperability is you guys are all like Ptolemy, right? You're thinking of the world the wrong way. You really ought to be thinking about it this other way and make everything available to patients, and the world will be great, right? We'll have consumer choice, we'll have all of that. So why didn't we do this before, you might ask? Well, a couple of reasons. One is that I don't know why, actually. One, I guess we just didn't really think about it in quite that way. The internet revolution hadn't really, sort of taken hold in the way it has now that allows a lot of individual empowerment and a lot of mobile technology and the growth of the web and the growth of mobile technologies, right? I don't think it was obvious to everyone 6, 7 years ago that this was going to be the center of all of our universes, right? That you were never going to buy a small camera again, right? That business is gone. You're never going to worry about copying anything on a home copier again, right? You're just going to take a picture, it's going to be gone. You're actually never going to buy a thermometer and put it outside your window again, right? That's one that just blows my mind still, that instead of doing that, now I'm going to check my phone so that it goes checks the NOAA site, somewhere in the cloud and tells me what the temperature is when I could step outside my door, but no way I'm going to do that. I'm going to check it on my phone, right? We never imagined that that's the way the world was going to work. So, not surprisingly, we didn't really, I think we were constrained in a way. We're also constrained by technology. So back then, right, the only way that a patient could access the data in any scalable way, for those of you who remember the blue button, right? The blue button was supposedly a great innovation. What did it do? It allowed you to push a button and it downloaded an ASCII file with your medical records, right? And the VA and CMS implemented it, and then no one else did because it was ridiculous, right? No one was going to do that, and very few people did it, right? Because it was really cumbersome, it was awful, and then it always begged the question of, well, what the heck are you going to do with a text ASCII file once you've downloaded it anyway, right? So we were sort of, just sort of stagnant, right? Well, along comes web enablement, mobile devices, and in particular, now we have HL7 Fire. And HL7 Fire lives in that world. It lives nicely in that world, and it's the enabler to allow an ONC or a CMS to say, you know what, we actually have the tools now that we can have this conversation about flipping the equation. And we couldn't do that before because the tools weren't there. Maybe there was patient demand, maybe there wasn't, we don't know, but we couldn't even ask the question because the tools weren't there, but now the tools are there. Why do I care about HL7 Fire? How many of you have heard of Fire? Hopefully all of you have heard of Fire. How many of you feel like you know what Fire is? Oh, okay. Well, half of you, that's good. So, Fire, what's Fire? Fire is a way of exchanging data in the same way that Google, Amazon, everyone, Twitter, Facebook, it's a RESTful API, meaning when you look at, next time you're on your browser, going to Amazon, you may be doing that right now, look at what happens when you click on something on the Amazon site. You say, I want to buy this jacket. Look up at the browser bar up at the top where originally you typed in Amazon.com, and then the minute you click something, it explodes into a bunch of gobbledygook. That actually is a RESTful API. That is making a query to Amazon, and then Amazon is receiving that and is sending something back, right? Fire says, let's use that same paradigm, where instead I'm a physician and I'm going to click on give me those allergies, those medication allergies, sends out a query via that same exact sort of paradigm, and then brings it back, right? In that same URL concept, same browser-based technology, web-enabled, right? So it's great, right? It's light, it's very friendly, it's very mobile friendly, and it's in line with the way the rest of the internet economy works, right? So you sort of look at that and you think, oh, okay, now we have the ability to say we should put more of this in the hands of patients and see what happens, and maybe that'll solve all our problems. So how do we do that? So there was this standard, right, came about, actually it's been around for a little while, but a lot more work has been done recently to say how do we accelerate that and get that out to market faster? And I won't bore you with all the details of that history, I'm happy to, but a key part of it has been this, this initiative called the Argonaut Project that some of you may have heard of. It was a consortium, it is a consortium, it's still alive and well, of technology vendors, from general technology vendors like Accenture, for example, to large platform vendors like Apple and Microsoft, to EHR vendors, Epic, Cerner, Athena Health, Meditech, eClinicalWorks, all members of the Argonaut Project, as well as some large provider organizations who got together to say, if we're going to move to this Fire API thing, we'd better sort of test it and make sure that we iron out some of the wrinkles before we just put it out there, because otherwise people could be really frustrated and it's just not going to work, right? So that's what we did. We got together, we said, all right, we're going to bring together a group of players, we're going to put some money in a kitty and basically run a whole bunch of, sort of coding sprints essentially to make this stuff available faster than it might otherwise be available. So we published an implementation guide that basically said all the stuff that you would get in that common clinical data set that I showed you before, which is what CCD payloads contain, right? For those of you, now are familiar with that, that's what you get, right? When you send a direct message or when you query for something and get it back, you get the CCD payload. The Argonaut implementation guide said, we're talking about the same payload, but what we want to do is be able to enable a RESTful API, this kind of browser-based technology, to get all that data or to get one data element at a time, to just do what that physician really would like to do, which is just give me the allergy. That's all I really want. I don't want 80 pages of gobbledygook. I just want the allergy and just bring that back to me. Right? And that opens up a lot of other opportunities to do other cool things. Right? So that was the implementation guide that got published. And that put us on a pretty fast track, amazingly. So we started in December 2014. We published in December 2016 that implementation guide, published a bunch of other implementation guides. And for anyone who thinks that healthcare is moving too slowly and we're really behind interoperability and all of that, I would just point out that remember that date, December 2014, where we launched the Argonaut project. And then what happened? In January 2018, so 4 years later, Care Quality, Commonwealth, and ONC have FHIR APIs baked in to their systems. And most important, actually, Apple includes the Argonaut implementation guide specification in the iPhone, right? And not as an app, baked into iOS 11.3, right? So in 4 years, we went from starting a project to the most ubiquitous consumer platform in the world, baking it into the kernel, baking it into the operating system and taking that specification, right? So that's pretty short, right? I think all of us would agree that, by any measure in any industry, that is a really short time for, for that to happen. And it shows a little bit of how once we align these healthcare standards with, with the way the rest of the internet economy was sort of moving ahead, that we're able to sort of ride that wave, right? And keep going and follow in behind it. So what does that enable and why do we care, right? Because the Apple, for any of you, how many of you have used your iPhone to download your health record? Is it still on your phone? All right. At the end, you may want to delete it. I'll tell you why. But who cares? I mean, at the end of the day, I'm sure you had this experience that you went, it's like, oh, this is cool. All right, I'm going to download iOS 11.3. I did this with my wife. I have an Android, but my wife has an iPhone. She was like, hey, let's do this really cool thing. And she's like, oh, okay, well, what? Here, let's download iOS 11.3. That took like literally, 90 seconds. And then let's go to Partners. That's where she gets her care and get your record. And it all happened like literally within 4 or 5 minutes. We were done. But then she was like, now what? What? It's like, well, there they are. There are your records. Okay, what's for dinner? Right? Because that's the end point right now. That's the problem. It's like, all right, great. Now I have my record. Now what do I do? Right? And that's not the end point, clearly. That's the first, some would argue it's just the first step, right? Just getting access to your record or having it in your control in certain ways. And the opportunity is around apps, right? Is for us now, despite the recent FTC ruling that's going after Apple, let's just pretend that hasn't happened and that the market still continues as it does today or in some form. The opportunity is to be able to say, now you can download cool apps related to things that you care about, like wearing red jackets and how it affects your health and being able to connect the, sort of the vitals and what you're wearing or whatever it is, but being able to have apps that do things that are customized to you and that take advantage of the data that you have control over and provide access to, right? That's really the goal here, and that's why we might be able to contemplate a world where maybe patients could be in charge. I'll submit that I'm not really sure that most patients want to do that, and that's one of the challenges that we have in front of us, so we'll talk about that in a second. But FHIR has been hugely successful, right? So we started with, I showed you 4 years from conception, literally conception. There was no Argonaut project. Then there was an Argonaut project. 4 years later, Apple bakes the Argonaut project implementation guide into its iOS 11.3. So now it's available on consumer devices. And then ONC goes out and collects a bunch of data on where is FHIR distributed in the EHR systems. And what they find is over half of the vendors are using FHIR and OAuth. Those developers cover 87% of hospitals and 69% of MIPS-eligible clinicians, right? So huge penetration of FHIR availability in EHR systems across the country. Right? That doesn't mean that everyone's using it, doesn't mean it's usable for any of the things you want it to yet, but at least it's there. Right? That's the first step, and again, in a very short period of time. So the foundation is there. The question is, are we going to use it, and do we really care about it at the end of the day? So one of the challenges, and here I'll get into some of the challenges, right? I've been telling you all the great things about fire and how it could possibly change our world, and now I'm going to reel it back and say, well, we have to walk before we can run, and we'll see how this unfolds. And as we know, all of this is dynamic, and things don't always play out the way we think they're going to. And one of the things about fire is, if you think about what a fire API allows you to do, is there's different types of data that one could get in a fire API. So I showed you the common clinical data set, right? Those 22, 23 data elements. Well, as you know, in an electronic medical record, particularly if you're in a large hospital system, for example, it's got tens of thousands of data types in it, right? And I was just showing you 25 or something like that, right? It's got tons of data types in it. It's like, well, all right, well, wait a minute. There's lots of other data. I mean, we're just talking about the structured clinical data. What about the unstructured clinical data? What about administrative data? What about financial data? What about all this other stuff that we want to be able to have? Then there's also other functions. Right now, the Argonaut implementation guide and what Apple has implemented is just a read capability. It just allows me to go in and get that data back into my system, and that's it. What if I want to update that data? What if I find an error? What if I'd like to make an appointment somewhere else, so I actually want to write data into another system and say, hey, I'd like to schedule this patient for a surgical consult next week? Well, none of that is a part of the Argonaut implementation guide yet. And then there's a question of uses. Right now, all those APIs I showed you on that map and everything is provider to patient. It's actually not about provider to provider. So it's not about partners exchanging information with Beth Israel Deaconess or Children's Hospital or with Steward Healthcare System. It's about Steward Healthcare System making data available to a patient via Fire API, one of their patients, right? That's all that's been enabled right now. And why is that? Because the current EHR certification requirements by the federal government just specify that. So that's kind of the common foundation that we have that you can count on across all these systems. But as you can see, it's really just a tiny, tiny, tiny piece of what Fire could sort of enable or allow as we go forward, right? So there's good news and bad news in that. One, the good news is, wow, a lot has been accomplished, and we just are sort of scratching the surface of what a Fire sort of based world could allow us to do. The bad news was that is, if it takes that long, then how long is it going to take us to get to all these other things? We may think that 4 years is a short time, but if we sort of say, well, it's going to take another 4 years to get us to write, and another 4 years to get us to all this other data, another 4 years, in the long run, we're all dead, right? So you got that problem. And you start, the years start adding up, months start turning to years. So the other challenge that we've been seeing related to that is, here is just sort of, I went onto their public sites, and these are the different vendors who now publish what APIs do they make available for providers or patients or different uses. And you can see there's variation, right? So there's a common floor that's related to that little red box, right? Not surprisingly, right? The only organization in this country that's big enough to be able to say everyone should do this, and then that means that most everyone does it. So whether I'm in Wyoming or Maine, I can have some degree of certainty that it's going to get done, is when Medicare and Medicaid say you have to do something, right? Everything else doesn't matter. But if Medicare and Medicaid say you have to do it, well, then everyone's going to do it. And so that's setting the floor. It's that little red box that I was showing you. And to the extent that you see commonality across these vendors, that's that little red box. But then what do we see? The vendors are going out ahead, right? They can't sit around and wait for the federal government or wait for these certification processes. So each of them develops in their own ways. And they develop certain things just depending on what their customers say they want. But the challenge is, now you're on the other side of this and you're thinking, I want to create that app that's going to be available on your iPhone. And I want it to scale. I don't want to have to worry about, is this a Cerner site or is this a Meditech site? I mean, what app developer has to worry about that stuff? Well, the reality is in healthcare right now, unless you're just doing that little red square, you actually do have to worry about that. So we have a scalability issue, right? So that's where these initiatives like the Argonaut project come into play, which is to say, let's all work together to see if we can raise this floor in a way that builds it into what Medicare and Medicaid require, so that this all gets filled in a more and more uniform way over time, so that I don't have to think about as a developer or as a patient, is that a Cerner site or is that an Athena Health site or is that an eClinicalWorks site, right? But there's a lot of work to do there, and we have that variation going on right now. So there are these accelerator projects that are working on that. So Fire, the Argonaut project, as I described, is a provider to provider or provider to patient kind of use cases, where what we do is we say, here are the things that we think are important. based on our understanding of the market, what the vendor customers are telling us, what the provider organizations are telling us. And that's the thing, those are the things we're gonna work on, like that implementation guide and scheduling and a whole bunch of things that, that we try to sort of say, let's get these out into the market as quickly as possible and get some group consensus around this so we don't have variation across the vendors. And there's another initiative called the Karen Alliance, which is working on payer-patient kinds of use cases, which is to say, you should be able to, as a patient, whether you're going to Anthem or Blue Cross or Harvard Pilgrim, be able to go onto their website or have your own app, be able to download the same information regardless of which health plan it is, right? And that's what they're working on. And then finally, you have the Da Vinci Project, which is working on provider payer. So to the extent that we've got all these, thorny issues around quality measurement stuff and differences in quality measurement or prior auth or all that stuff that drives people bananas, they're saying, let's get a group of payers together with a group of vendors and say, how do we sort of do the same thing the Argonaut project did, which is set a floor, a common floor that all of us agree to for things that we think are important, and then we'll just keep growing that over time, right? So these things are underway as accelerator projects, and so I think they're going to try to, what we're trying to do is say, let's move the FHIR standards so that it's more and more applicable in more and more use cases and more available to the market faster, so we're not having this problem of having to wait 4 years for this, wait 4 years for this, wait 4 years for this, wait 4 years for this. So, I think this is my last slide, actually, yes. So, all of this begs the question of, do patients really want to do this, right? So going all the way back to, could we flip this equation? And could patients really be at the center of this? And there are different perspectives on that. Some, like ONC and CMS, have a very strong perspective. And if you've heard Seema Verma, the head of CMS, talk, she tells a very vivid story about her husband collapsing in a hospital in an airport in California, and she shows up at the hospital with her husband. They couldn't get access to her records. If only she had his records on her phone, everything would have been fine, right? And she tells that story over and over again, and that is, sort of a lot of the driver is, sort of embedded in that story, that thought that if I just have all this stuff on my phone, then I can do all of this stuff, and I don't have to worry about my providers. I'm not dependent on my providers. I can't count on my providers. That's why I want it on my phone, because I can't count on them, and I want to be able to control it myself, right? So there's a very strong perspective on that. And then we say, all right, well, great, this FHIR thing comes along, everyone's web-enabled, everyone's doing this, with Home Depot and, everything else that they're doing on their iPhone. Well, that's great. Let me do my medical records on my phone. And then you have Apple Health Records, now available in iOS 11.3. Over 500 provider organizations have now signed up, so they're connected via, the records are available via an iPhone for any patient at any one of these 500 hospitals, and they've got another 500 or 1,000 hospitals who are waiting on that list, right? And the minute they announced that, every hospital CEO in the country was calling their CIO saying, how come I'm not on that list, right? They weren't lining up for care quality, but the minute the iPhone came out, it's like, oh, no, I need to be on that because that's where all the cool kids are, right? But Apple doesn't release this data, but the reality is very few patients are actually doing that. They're doing these as experiments, as a novelty, but the reality is there aren't that many. Now, we don't know the numbers, but we know that it's not that many, right? Which is very consistent with patient portal use and view, download, transmit, and all of that stuff that we've made available to patients, right? So that's one challenge that we have is the reality of, so going back, I'm not convinced that patients are going to be the driver of this. I do firmly believe that patients ought to be given the opportunity and given the tools to be the driver of it if they want, but still unclear whether they're going to be the drivers of it because they may not care about it. They may be more like me, which is I just want my providers to exchange the information and be assured that they're exchanging the information. I'll vote with my feet to go to providers who I know do that, but I don't want to be at the center of it. I don't want to be responsible for it for a number of reasons, and one of the reasons I don't want to be responsible for it is this last piece that I'm going to talk about right now, which is the security and privacy element. So one of the big challenges in the world that we live in right now is actually, why don't I show you this and then we'll talk about it. So here's two representations of an electronic medical record available for a patient on a mobile device. Right, two representations. These are both different, right? So they're both on an iPhone. They're both different representations, different technologies. And the question for all of you is, are either of these protected by HIPAA? Or which one is protected by HIPAA? One person says none. all right? So I'm hearing people say once it's in the patient's hands, it's their responsibility, right? So that gets to the second part of, well, I guess we'll have to ask the question of should we care? It turns out that one of these actually is protected by HIPAA. Which one is it? It's not this one. This is the iPhone. This is yours. You've downloaded your record over here. This is Epic's MyChart app on my phone. This actually, it turns out, is protected by HIPAA. Why? Because the data isn't on my phone. The data is being made available to me by a technology that the provider controls and is therefore covered by HIPAA. So if anything goes wrong with that, it's not on my phone. First off, the data's not on my phone. How would I know that as a user? Well, there's no way that I would know, right? How would you possibly know that this, how would you possibly know that on this side, I keep pressing the wrong button, sorry. That on this side, this data is actually being made available over the web, but it's just being rendered on my phone versus this is showing data that's actually on my phone, right? There's no way that you would know as a lay observer just looking at that. But it turns out that if I downloaded, let's say, ZipRecruiter, or I downloaded, let's say, OpenTable. What if OpenTable said, hey, I see you got some medical records on your phone, and if you have any food allergies, do you want to give us access to that so that when we're making reservations, we can actually send that to the restaurant in advance, right? And you might think, wow, that'd be really cool, right? And to the extent that you think, no, I would never do that, think about all of the compromises you make every single day for convenience and privacy, right? That is always the issue with privacy. It's why we use Gmail and don't even worry about the fact that Google reads our emails, right? We send everything over Gmail. I know I do. It's like, well, they're not going to care about me, even though I know they're reading my emails, right? They have absolute access to it. There's no issue. And we do it for convenience, and we do it because it's cheap. So no doubt about it, right? What if OpenTable said that? And so I just click through and say, yeah, sure, fine, great. And now we live in a world where our pre-existing conditions are seriously at risk, right? That's a serious government policy being entertained. And that small mistake I made, I didn't realize it was a mistake, it wasn't a mistake at the time, is now following me for the rest of my life. And there's nothing I can do about it. You can't sue OpenTable, you can't sue Apple, you can't sue anyone. You can't sue your provider because the data was in your hands. On this side, if OpenTable ever got access to that, you could absolutely go after the provider, you could absolutely go after Epic because it's their responsibility to make sure that their system is not hackable. Now, if you gave the username and password, that's your issue, right? But if they hacked in and there's no ability for you to say, I'm granting access to this other third party, right? You can't do that on the MyChart app. The only way you can do that is giving someone else your username and password, which would be obviously a foolish thing to do, right? So it begs these really important and hard questions where this data starts to go over the wall into the non-HIPAA covered world, the non-HIPAA protected world in ways that patients don't even know what the implications might be. And we have no laws in the US, right? If you're in Europe, it's different. But here in the US, you literally are almost bare naked out there. Unless there's a breach, the FTC would cover a breach, but we're not talking about a breach. What I just described wasn't a breach, it was with your permission that you gave that data to OpenTable, and OpenTable can do whatever they want with that data, or ZipRecruiter or any other app that you want to click through. So everyone on your iPhones, I would delete your medical record right now until there are protections. Now, Apple is a very good citizen in this regard right now, right? We're relying on the good graces of a company that actually is putting up very strong firewalls around it, so I think it is protected on the iPhone. But the point is, you're relying on a company's policies, you're not relying on anything else, and there's nothing else standing behind it. So anyway, I hope that didn't leave you with a negative sort of perspective on all of this. I mean, I think it's really exciting, and I think it has the prospects for adding another sort of frame on interoperability and another way to richen the experience and perhaps to move healthcare in different directions. At least it opens it up to other possibilities, but we still have, in some ways the technology has gotten out ahead of the policy, and so we need the policy to catch up before we can really figure out what this is going to do for healthcare. So thank you very much. I really appreciate your taking the time to listen. Sorry? That is the last slide, yes. Oh, sorry. Thank you.